Very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is no other than Dr. Wojciech Zudzek from Poland, and he's going to lecture us on mantle cell lymphoma with the new things on EHA and Lugano. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Glenmark, and very well managed by Perfect Square. I thank Mr. Amaninder Dillon and Team Glenmark, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest today, Dr. Rajesh Patil from Mumbai, our guest speaker for the day, Professor Jurzak from Poland, all our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for sparing a Sunday morning, afternoon, or evening from whichever part of the world you logged in. Let me give flavor of our next weekend activities. Next Saturday, that is 22nd of November 2025 from 6 p.m. Indian Standard Time, we have hematology updates and we have got 3 lectures. The lecture 1 is on belumosudil in chronic GVHD, a new pathway to control fibrosis and inflammation, followed by a panel discussion again on belumosudil in chronic GVHD, a new pathway to control fibrosis and inflammation. And then we have got lecture 2, that is on intensive chemotherapy with venetoclax in newly diagnosed AML. And the lecture 3, we have approach to bone marrow failure syndromes. Following day, that is Sunday, 23rd of November 2025, we have got again 2 lectures. Lecture 1 is at 10:45 am Indian Standard Time, from transfusion dependence to independence in frontline MDS, commanding results with Rojusta by Dr. Rahul Arora from Max Hospital, Nagpur. And following this, we have got lecture 2 from 11:30 am Indian Standard Time and 7 am Italian time, how to use luspatercept and erythropoiesis stimulating agents in low-risk myelodysplastic syndrome by Dr. Valeria Santini from Italy. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. I will pause for a while for you to look on all our discussants of the day who are very eminent hematologists, hemato-oncologists, as well as medical oncologists all throughout the country. Some more over here. Well, so these are our discussions for the day. And now it's a time to introduce our guest speaker for the day, Dr. Jurzak from Poland. Dr. Jurzak is MD, PhD, consultant, and professor of hematology at Memorial Maria Sklodowska-Curie National Research Institute of Oncology at Krakow, Poland. He is a consultant and professor of hematology at Jagiellonian University, Krakow, Poland, where he leads the lymphoma team since 1992. Most of his research activity in the first 15 years is related to development of monoclonal antibodies in B-cell lymphomas and practical aspects of stem cell transplantation. Jagiellonian University lymphoma he leads and has participated in over 70 clinical trials, including phase 1 and phase 2, followed by expansion cohorts. He is a co-author of publications leading to registration of ibrutinib, idelalisib, belinostat, lenalidomide, venetoclax, and rituximab biosimilars. At present, his research is focused on developing future generation BTK inhibitors, anti-PD-1 molecules, DARTs, and BiTEs. He is a member of numerous scientific societies, namely ASH, ESCO, PLRG, EMCLN, and ICOS, and consultant for EMA, that is European Medicines Agencies. His research papers have been published in NEJM, Blood, JCO, The Lancet, Lancet Oncology, Annals of Oncology, with a cumulative IF of more than 650, an H index of 20, and citations of more than 3,000. Today is with us and is going to lecture us on mantle cell lymphoma with the new things on EHA and Lugano. But before he does that, let me introduce our special guest and chief guest for the day, my friend Dr. Rajesh Patil from Mumbai. Let me introduce Dr. Rajesh Patil to all of you. We all know him very well, but it's my formal duty to introduce Dr. Rajesh Patil to all of you. Dr. Rajesh Patil is a clinical hematologist trained in internal medicine at Grant Medical College, Mumbai, followed by DM in clinical hematology at ZGS Medical College and KM Hospital, Mumbai. He further pursued a fellowship in bone marrow transplantation at Christian Medical College, Vellore. After his fellowship, he worked for nearly 7 years as a transplant physician at the CTC PHO BMT Center, Borivali, a satellite center of LTMMC Sion Hospital, contributing to more than 400 stem cell transplants of various types. He has extensive experience in managing both benign and malignant hematological disorders, with a special focus on stem cell transplantation and novel therapies. He is currently practicing at Jupiter Hospital in Thane. His work spans leukemia, lymphoma, myeloma, aplastic anemia, and other complex hematological conditions. He remains committed to delivering advanced, compassionate, and evidence based care to his patients while expanding access to cutting edge hematology and transplant services in the region. It's my privilege to welcome Dr. Rajesh Patel to inaugurate a webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Rajesh Patel.
Good morning, everyone. I'm Dr. Rajesh Patel. First of all, I thank Dr. M. B. Agarwal, sir, Dr. Amit Khurana, and MHG to give me this opportunity uh, for, in this webinar. So my introduction to hematology happens in 2009 when I was doing uh, my residency in medicine, where we have come across a case of anemia, which was not a routine nutritional anemia, for which I've taken that patient to Dr. M. B. Agarwal, sir, and that time the patient was diagnosed as hereditary spherocytosis. So this diagnosis has ignited some curiosity under me for hematology, and gradually I decided to follow the footsteps of my dear senior Dr. Nilesh Vasekar and ended in a TM hematology. So hematology was a wonderful branch. We got uh, hand-to-hand learning from our mentors, Dr. Chandrakala and Dr. Farah in KM, and later on we learned higher aspects of hematology in ACTREC with Dr. Naveen Khatri and CMC with all the stalwarts. My further journey, I learned a lot of things regarding pediatric hematology and then transplantation works in pediatric field, mainly with Dr. Mamta Mangladi, where I have learned along with academic social aspects and more towards the empathy towards the patient. So my few words of wisdom for the budding hematologists here. So as we all know, the first few years of hematology training can be quite daunting. So, but we have to stay there at that time, hold ourselves at that time. That better to speak with our peers, mentors at that time, confide with our family members. That few years definitely requires the help at that time. Later on, discuss your cases, discuss your doubts, success, and even the failures with your close colleagues and peers. Sharing the knowledge makes the community stronger and it helps each other to cope up and grow together. Over a period of time, I think we should all develop the mindset of collaboration, work together, support each other, learn from each other. And this spirit of harmony will not only make the ourselves progress, but it also elevates the entire field of hematology. Thank you very much for making me guest in this meeting. Over to you, Dr.
Thank you so much, Dr. Rajesh Patel, for that kind words. It means a lot to all of us. And thank you for accepting our invitation as our chief guest for the day. Thank you so much. And now, Dr. Jurzek, the screen is yours. Please go ahead.
Hello. Thank you so much for being here. It's a foggy morning in Krakow, 7 a.m. Now, I would like to speak for you the mantle cell lymphoma, where we think we have what I call a smoldering evolution, if not revolution in therapy. By the way, every time I remind myself the time I spend in Mumbai, well, we are proud of our city, but it's just less than 1 million. But at least we have what we call the largest main marketplace in Europe. So you understand that everything we do have in Europe is in micro scale compared to what you have in Mumbai. Now, 2 decades ago, diagnosing mantle cell lymphoma was a problem. I remember that once we started European Mantle Cell Lymphoma Network, we had pathologist panel to train pathologists of how to recognize this entity. Since then, we had a long way. Nowadays, it's not just diagnosing mantle cell lymphoma, but looking for the risk factors, which is absolutely essential. And one of the most important things we should always try to do is we should try to look for P53 mutations, not deletions like in CLL. The FISH analysis doesn't help us. It is mutations, so we need to use the same technique as we use for CLL mutations, with NGS being the most commonly used. Now, to do it, we need to have a liquid tumor.
Mobile on routes.
Yes. Sorry. So to do the NGS testing, we need to have a liquid tumor sample, which means you can't do it on the slides. We can do it either on the blood sample if we have mantle cell lymphoma cells in the blood, bone marrow, or if we don't have it, we should go for aspiration biopsy of the lymph node. Now we can have some conclusions on immunohistochemical staining of P53 as well, and a very, very high or a very low expression of P53 might indicate us indirectly that we have mutations. The other thing which is absolutely obvious I want to draw attention to is the CD20. And in mantle cell lymphoma, CD20 is very nicely expressed as opposed to chronic lymphocytic leukemia. Therefore, we cannot take all we know about CLL therapy to mantle cell lymphoma. In CLL, if we compare the Amplify data, we may have discussions whether or not we need doublet or triplet, whether or not anti-CD20 is necessary. In mantle cell lymphoma, with a high CD20 expression, it is compulsory element of any therapy. But the good news is that we can use the old rituximab or rituximab biosimilars as it's good enough. For CLL with a scanty expression, we need a better monoclonal like obinutuzumab. And who likes obinutuzumab in terms of its administration and price? In mantle cell lymphoma, the old rituximab is good enough. We still have we have identified the indolent mantle cell lymphoma, which is usually leukemic in picture, which is has involvement of blood, bone marrow, spleen, but very few, if any, lymph nodes. Such patients are usually SOX11 negative, and like other indolent lymphomas, we may observe those patients. We do not have the necessity to treat them. Now, we have a classical nodal mantle cell lymphoma. We may still observe it for some time, and this sometime means that we have time to sort the patient out. The most important being just COVID vaccination. So if I have a patient with a mantle cell lymphoma, which is not with vigorous B symptoms or large tumor burden, and he is the anti-vaxxer, we have a friendly conversation, after which 95% of those patients change their mind and vaccinate themselves. It's so necessary because in mantle cell lymphoma, we do use rituximab for a long time with rituximab maintenance. And the classical mantle cell lymphoma undergoes cytogenetic evolution, with translocation 1114 being the initiating factor. However, the longer the mantle cell lymphoma, the more mutations, and eventually we have the hallmarks of the high-risk disease, which means the P53 mutation, high Ki67 complex karyotypes, or even a blastoid pleomorphic morphology. Now, before we start, I just want to take you to a historical journey, and if we compare of the results of mantle cell lymphoma treatment we may quite clearly understand that the progress has started before BTK inhibitors, and it was possibly due to rituximab and rituximab maintenance. That's again the reason why we should consider vaccinating the patients against COVID, as those who are not vaccinated are doing worse in terms of statistics, not just in progression-free survival, but in overall survival. Now, if you look at the results of therapy after failing first-line therapy, we see that it does depend when is the failure. Just like in other indolent lymphomas, the POD24 patients do worse, and if we have the POD6, it's extremely poor. Therefore, improving the first-line results does matter. Most of our patients will sooner or later be refractory to the first-line therapy, and unfortunately responses to subsequent lines are shorter. Now, we should ask ourselves a question whether the identified high-risk mantle cell lymphoma patients are the unmet medical need. And those high-risk patients at the diagnosis are can be either identified by the classical histological picture, those plastic pleomorphic features. The patients with TP53 mutations, and look at that, they are doing particularly badly. Perhaps less so those with high Ki67 index, but high index is everything more than 30. So we're not looking for 80, 90%, just 30% is good enough. And certainly the POD status we can't know at diagnosis, but if we have a relapse and refractory cases, it's important. So are we ready to recommend a risk-adapted therapy in the first line? It's a good question, which grossly depends on what is reimbursed and what is not, and what is covered by your insurers. Now, here again, I wanted to address which is more important, POD or mutational status. And as you see, this curve 3 and 4, the POD is important for overall survival, but the mutation status is much more important. There's the old European mantle cell lymphoma guidelines we all know, where we have in we divide the patients to the younger and the elder. The younger one should be treated with intermediate dose cytarabine followed by the transplant, but in both cases we need a rituximab maintenance. Now, BTK inhibitors were a breakthrough in relapsing refractory setting, and in a high relapse we thought about pirtobrutinib or CAR T cells. This is more or less corresponds to what we observe in real life. These are data from 2023 of analysis of over 4,000 patients. And as you see, in the younger population, the cytarabine-based regimen are popular, and they are about 20%. And this is what we do transplant. We do not transplant more than 20% of the patients. The majority of patients are elder, and here bendamustine rituximab looks to be the most popular scheme. And I want to be intrigating here, and I want just you to realize that bendamustine rituximab with maintenance is a much better cycle than R-CHOP with maintenance, and every cycle of maintenance is better than without. And this is this red or yellow curve on time to next treatment and overall survival. So by adding the maintenance, we do change overall survival, whichever the chemotherapy we use, whether we transplant or not. We need to maintain those patients after the transplant as well. But if you look at the transplants, we do have a difference, even in overall survival. regarding whether we do it correctly with intermediate cytarabine doses or incorrectly with R-CHOP. And this curve with R-CHOP, which is the red curve, it gives you the median time to progression or the median time to treatment failure in 4 years, which is less than bendamustine rituximab with rituximab maintenance. So it's better to verify the patient's status if he or she is not eligible for transplant, to treat them with bendamustine rituximab with the maintenance and not R-CHOP plus transplant. Now, in EHA, we had an initiative where we we created, I'm saying we because I'm a member of the guidelines committee responsible for lymphoid malignancies, the true EHA guidelines, which are being published in Hemisphere on a yearly basis. They will have once a year upgrade either on our webpage or as a letter to Hemisphere. We have the application as well. Mind you, this is the EHA logo. Don't ask me who made it. I think that you can't even appreciate how unlegible, how awkward it looks, because an original logo is not just illegible, it's turning. If it's turning, you don't see anything. But I hope that our guidelines will be more recognizable. We plan to have 30 new guidelines expected in the next 12 months, and there are already a couple of them hanging on the page, including diffuse large B-cell lymphoma and mantle cell lymphoma. And if you look at, if you compare NCCN to EHA, there is a slightly different way we look at it, because the category 1 and 2 is based on randomized trials, that's for certain, but then the NCCN goes for the consensus within the panel, while we go in Europe for a proof, like we look at the category 2 are small randomized trials or large randomized trials with a suspicion bias. So we are more predictable. Now, the other thing is that we have more categories. It's not just a preferred intervention, but we have a strongly and generally recommended, which are different, because generally recommended is something which is well proven, but with a limited clinical benefit. So category A is a must, category B or C are not a must, particularly if the therapies are not reimbursed. And this is what's our new guideline published just 2 weeks ago. And as you see, we acknowledge that in a limited stage first line, we may just observe the patients. We do not have to treat them, although we just know it from the observation of cohort studies, it's a recommendation grade 3. Now, we still keep the fit and unfit patients, and the fit patients, wherever possible, we recommend the triangle study. So we recommend not just the intermediate cytarabine dose, but intermediate cytarabine dose with ibrutinib, certainly with ibrutinib and rituximab maintenance later. Ibrutinib for 2 years, rituximab maintenance for 3 years, not for 2 years. Now, if we can't get this, we still have a lot of possibilities without BTK inhibitors. We put those guidelines this way to allow for the countries where the ibrutinib is not reimbursed. But I hope that in the next year it will not be the issue anymore, as ibrutinib is losing its patent rights, so it should be marketed in the price of chlorambucil. At least we hope so. Now, in elderly or unfit patients, again, we recommend chemoimmunotherapy for those countries where acalabrutinib is not approved in this setting and not reimbursed. And certainly we do recommend bendamustine plus acalabrutinib. However, what's very important, we went for MD Anderson experience, although we clearly indicate that it's neither improved by EMA or FDA, or in elderly patients, we may just go for rituximab and BTK inhibitor. The NCCN guidelines are ahead of us in a way that they identify TP53 mutated patients, and even if we are talking about indolent mantle cell lymphoma with TP53 mutations, once we need to start therapy, the therapy should be different and should be either in a triangle regimen for the youngsters or should include a combination of BTK with venetoclax and obinutuzumab. Certainly, the maintenance is recommended as well. So this is what we came through as a kind of combination of the two. But let's talk about what's at the moment the standard of care, and we regard it the future because it's a revolution of what we thought before. So let's discuss whether we should use BTK inhibitors in the first line. We have a couple of studies addressing this question, starting from the SHINE, where we used BTK inhibitor with or without bendamustine rituximab with or without BTK inhibitor. But all of those studies had a progression-free survival as the primary target, which makes me think that they're not straightforward, because if we are taking a BTK inhibitor which is efficient in the second line to the first line, just a mere win in PFS is not good enough. We should at least have the progression-free survival which is longer than progression-free survival with the old regimen plus the median progression-free survival of BTK inhibitor in the second line. The studies differ because the first two take bendamustine rituximab and they include maintenance. The Heinrich study includes maintenance, but it's just a non-chemo protocol for bendamustine because it's just rituximab plus BTK inhibitor. And Mongrove study, the only one without the outcome, has an even better BTK inhibitor, but has no maintenance. It will be an interesting study, but I think it's not a good option. SHINE, the protocol was, as I mentioned, the key endpoint was progression-free survival. We randomized 523 patients, and we got quite a important and significant progression-free survival and nothing in overall survival, nothing, which made us be pessimistic about this protocol. In a SHINE subgroup analysis, we did have some improvement in patients with blastid or pleomorphic morphology, so it was better, and non-improvement in TP53 mutation. Just an ibrutinib is not good enough for this high risk group. And again, we achieved in a subgroup analysis the benefit, the progression-free survival benefit in all risk subgroups. However, certain did better, like intermediate risk, or those without a large tumor burden. The adverse events were comparable. We couldn't truly say that it was bad, but the study was performed at the beginning of pandemic, so we had some problems with COVID. In the Heinrich study, the one we just had our chemo versus bendamustine rituximab versus ibrutinib rituximab, we had a clear benefit of ibrutinib containing arm, but it's very important to understand that this benefit is not observed in a blastid or pleomorphic morphology. Therefore, if we decided to go for rituximab BTK inhibitor only, a non-chemo regimen, it should not be recommended to the patients with a blastid morphology, as they have an inferior outcome. The idea to combine ibrutinib plus rituximab came from MD Anderson, where the original presentations from 2020 demonstrate a formidable progression-free survival. For the younger individuals, they recommended a ibrutinib-containing first phase followed by chemotherapy. But what's really nice is a window 2 study where they used ibrutinib plus rituximab with venetoclax, so a triplet, and then they had a risk stratification. We're in a low risk group. There was no further treatment, and then the amount of chemotherapy depended on the risk group. And again, a magnificent curve, but dramatically expensive regimen. So there are lots of covalent first generation BTK inhibitors which are being explored with a variety of combinations. It's off notice, but not generally recommended. The ECHO study, which led eventually to acalabrutinib approval, so again a very simple designed 598 treatment-naive mantle cell lymphoma patients randomized for progression-free survival being the first primary target. The study allowed a crossover to acalabrutinib after progression disease, which means that we can't really comment on overall survival. The progression-free survival was clearly different, achieving the median progression-free survival of 66 months. And those on acalabrutinib had a deeper regressions and therefore more MRD negative cases, and those cases did better. With the overall survival, it's again the question whether we took the whole population where we see a scanty difference, or whether we censor this for COVID. And if we do that, there is an overall survival benefit, and that's why, based on ECHO study, acalabrutinib is approved in the first line by EMA. Now, talking about this COVID study, I would like to draw attention to the sub-analysis of Amplify study. That's a CLL study. But there we did quite a nice analysis addressing the question of COVID-related mortality with two assumptions. The first assumption was that the worst was the second wave of COVID, and there we encountered most of the deaths. And the second assumption is that the vaccinated patients did much better. We didn't lose any one of the vaccinated patients. And interesting, it doesn't matter when we vaccinated. If we vaccinated the patients a month before initiation of therapy, that was good enough. Therefore, again, I would like to underline that unless we have an express disease with a blastid morphology and so on, and we have an unvaccinated patient, we should have a nice conversation with him and be rather persuasive. The adverse events of ECHO were what we would have anticipated. Certainly, if we use acala plus rituximab and not ibru plus rituximab, as in Altimira study, the results are similar to window protocol. As I mentioned, Mangrove study is not yet known the results. So how should we treat the high-risk patients? In ASH, they even said, well, chemo is no good in a high risk, but we should distinguish between other or high, we should distinguish between TP53 aberrant where we should go for clinical studies or a combination with BTK and BCL2 inhibitors, and of the other high risk, which means blastoid pleomorphic morphology, and that's definitely where the non-chemo option may not be the good one. A simpatico study, we did have certain treatment-naive patients who we treated with ibrutinib plus venetoclax, and the results are reasonable. So if we think about a possibility of treating a high-risk elderly patient, a high-risk, so a P53 mutated patients, the combinations of the two gives you an appealing good results. And certainly the results are worse than those of unmutated, but better than anything else. In the transverse study, we have adult patients with treatment-naive mantle cell lymphoma. We have the same thing, but not with ibrutinib, but acalabrutinib, and we added rituximab as well. And we changed our therapy dependent on MRD disease. The very similar answers, so a high response rate with an increased amount of patients of a complete response, but there is one but. The transverse study, as opposed to the simpatico, was PET-based and not CT-based, and therefore we could have relatively more complete regressions, as all those patients with a non-active lymph nodes which did not resolve totally could have been addressed adequately. Again, the COVID stuff, so again, the same story. Bovin, the same results with zanubrutinib. I'm just giving the studies to give you the hint that it doesn't really matter which BTK inhibitor we use. The BTK inhibition makes the difference. Now, the next question I'm going to ask is the role of stem cell transplant. And certainly we went for the long way. Once at first we regarded it absolutely mandatory for all the patients we wanted. But then we had a triangle study in which over 870 patients were randomized by European Mantle Cell Lymphoma Consortium into the patients going for the transplant in a traditional way, those who got ibrutinib instead of transplant, and those who got both ibrutinib and the transplant. But in here we should say that ibrutinib was just given during R-CHOP. It was not given during DHAP. So in fact, we had 3 cycles with ibrutinib during induction. The groups were well balanced, with the majority of patients in a low MIPI score, as it happens in the youngsters. And no wonder, but both arms with ibrutinib were superior to the arm without ibrutinib. So yes, the answer is we should use ibrutinib whatever happens. Now, ibrutinib, we randomized those, if you look at the results of high-risk group transplanted and not transplanted, so those who went for ibrutinib only and ibrutinib and a transplant, we could see no difference in the patients with low Ki-67. So perhaps in those patients we can stick to ibrutinib only without proceeding to transplant, but transplants were rather necessary in those patients with a high Ki-67, and this was statistically significant. Now, as for the blastoid variant or high P53, the additional transplant was maybe recommended, but did not achieve statistical significance. So for these patients, we should talk them through, but not made the decision for them. Adverse events were manageable. Now, in the Acrine study, where we look at the MRD, the time of transplant, because if the patients were MRD negative, we randomized them for sorry, because what I wanted to put you here is that MRD negative group, we randomize them for the transplant or not. It doesn't really matter whether we transplant them. With MRD positive at the time of transplant, we do need to transplant them. That's the key message. But that's again self-explanatory. So if we achieve a good enough result before transplant, perhaps rituximab maintenance is the only thing we need, and the transplant is not necessary. In an MRD positive group, it's evident that we should proceed to something more. And here is a kind of summary that Martin Dreiling gave. So again, if we have those youngsters, which we may treat vigorously, if we have high risk group, but no TP53 mutation and if we have youngsters without TP53 mutation and with low risk, we perhaps should omit transplants. If it's high risk with high Ki67, we should transplant them. If it's a blastoid morphology or blastoid morphology, we may discuss the transplant with them. If it's a TP53 mutated, we should also discuss the transplant with them. But if we have alternatives in clinical studies, it should be taken into consideration. The studies we have, and it's in a high-risk mantle cell lymphoma, and it's the colors which is important here, because as you see, it's ibrutinib only. Then here we have ibrutinib and venetoclax, and here we have something on top of that. And indeed, in the TP53 mutation patients, we would go for the doublet. And for the very high risk, I just want to draw your attention to the studies where the CAR T-cells therapies are used to consolidate those cases, but that's still investigational. Now, whatever we do in a primary setting, the relapsing refractory mantle cell lymphoma is much worse. And we influence our therapy depending on the prior therapies, depending on molecular features and certainly some patient factors. And that's our present European guidelines, where if we have a relapse post-line immunochemotherapy, it's a different way that if the patients are BTK exposed. So in a BTK naive relapse, we still go for covalent BTK monotherapy or a combination of BTK with venetoclax in a second line. And for the third line, we have the pirtobrutinib or CAR T cells. However, if the patients have already been exposed to BTK, that's a variety of choices. And in this case, I just want to remind you that pirto is approved in those who are BTK refractory. Now, a good case is whether and what should be first, the CAR T cells or pirtobrutinib, but this is to be discussed on an individual basis. I personally try to treat my patients with pirtobrutinib first, followed by BTK inhibitors, followed by the CAR T cells. The very same thing in NCCN guidelines, really. The BTK, as we mentioned, are approved in mantle cell lymphoma. The first patients we dosed with ibrutinib in 2007 in our center, 2009 in our center, but it's like a stone wheel. It is a breakthrough, but the question is who will use the stone wheel at the moment? The second generation BTK inhibitors are much better in terms of the toxicity, and we have pirtobrutinib, which perhaps will become the standard of care in the nearby future. All those drugs are approved in the relapsing refractory setting, with pirtobrutinib being approved in those who are already failing the previous BTK inhibitors. Now, just one explanation why we still use ibrutinib in Europe and in the States. It's not approved. Ibrutinib was approved based on phase 2 studies, and it got an accelerated approval, and the full approval was given in the randomized study where we randomized ibrutinib versus temsirolimus. However, in the States, temsirolimus was not an approved treatment for mantle cell lymphoma. Therefore, in Europe, ibrutinib has a full approval, so we can still use it. In the States, ibrutinib had only accelerated approval. Time expired. FDA had to withdraw its approval. Interesting case. I think that there's not such a difference, and I think that each of us will have to make his personal choices. We do know that the more selective the inhibition is, the less the off-target inhibition and the less the adverse events. I just want to draw attention that pirtobrutinib is not just overcoming resistance to the first and second generation inhibitors, but is exemplary selective and is possibly the least toxic of the all four. I'm talking a lot about pirtobrutinib because if you go to ASH this year, you will hear at least 2 presentations about comparing pirtobrutinib to ibrutinib or pirtobrutinib to bendamustine rituximab in treatment-naive CLL. And without being allowed to say too much, I may just tell you that the pirtobrutinib versus bendamustine rituximab, we were appointed the late-breaking abstract session, and in both abstracts we will have a simultaneous JCO publications, and it's very likely that pirtobrutinib will be approved in the first line of CLL in the nearby future. But if we're looking about efficacy, it all goes with IC50, which is a concentration that we have 50% of inhibition of bruton thyroid kinase. And you see that ibrutinib allows it for 6 hours a day, acalabrutinib twice 6 hours a day, but zanubrutinib is round the clock. So zanubrutinib in monotherapy perhaps is the most potent of first and second generation BTK inhibitors. And with zanubrutinib, we can quite confidently reduce the dose without losing the efficacy. And summarizing again the studies you all know with ibrutinib, which is quite efficient. What matters is whether we have a complete response, and it's trivial that we complete responders do better, but it also matters in which line of therapy we give it, and we should go to use BTK inhibitors as early as possible, so it's the best drug for the first relapse and not for subsequent relapses. A similar thing with acalabrutinib and zanubrutinib. If you think that the curves looks better, we cannot compare between the second phase protocols, and there was an important difference as in both acala and zanubrutinib studies. The median number of lines of therapy was 3 and not 4. Therefore, they were used earlier, and therefore the results were better. Now, if we have a lot of explanations of why why pirtobrutinib overcomes the resistance to covalent BTK inhibitors, it means that we truly don't know. It's evident that this mutation in 481, the cysteine mutation, is not important in mantle cell lymphoma. Therefore, we don't know why pirtobrutinib does overcome the resistance here. In the era before pirtobrutinib and CAR T cells, the patients were relapsing who were refractory or relapsing on the covalent BTK inhibitors did extremely poor, with median overall survival between 3 to 5 months. And this was something which we really didn't like before the pirtobrutinib era. So if we ask ourselves the questions, what shall we do for the patients with failing BTK inhibitors? We have two approved options, pirto and CAR T cells, and we may go for the clinical studies, particularly the BTK degraders or sonrotoclax. And sonrotoclax is something we should take into consideration, as it's a much better BCL2 inhibitor than venetoclax. I remember that we once put 9 patients failing pirtobrutinib to a sonrotoclax monotherapy study, and all those patients responded. Some of them are still in remission. So again, the same thing, pirtobrutinib CAR T. With biospecifics, I'm not that certain, because biospecifics in diffuse large B-cell lymphoma have an established role, and we can compare them with a CAR T cell. In mantle cell lymphoma, we do not have enough data yet. But pirtobrutinib binds to BTK in a different non-covalent ways. Therefore, we are not this cysteine 481 position is not necessary, and it gives you the excellent 24-hour coverage. But if in zanubrutinib we are talking about IC50, here we are talking about IC90. So for the 24 hours a day, pirtobrutinib allows to inhibit more than 90% of BTK. Therefore, again, reducing the dose of pirtobrutinib is fully possible. And whatever we say, looking at this high-risk group, I remind you the original data where we had between 2 to 5 months of overall survival in the patients failing BTK inhibitors. Here we have at least 50% with partial regression or complete regression, but another perhaps 40% merit out of it, because 20% have some reduction of the tumor, another 20% have a slower down of the progression of the tumor. And it happens in all risk subgroups analyzed. You may say that 6 months of median progression-free survival is not good enough. Perhaps it isn't. But if you compare how far we are, 2 to 5 months of median overall survival, now we have 23 months of median overall survival. And those patients who react to pirtobrutinib, so again, going back to the slide where I told you that we don't know how pirtobrutinib overcomes resistance, we don't know how to identify those patients, but if the patients react to pirto, the results are very reasonable, and the duration of response is medium duration is 21 months. Pirtobrutinib does pretty well in Ki-67, although inferior to the patients with a low Ki-67, and it also, as the first drug which in monotherapy also works nicely in TP53 mutated patients. Now, I've talked you through the studies. We will present this ASH on with CLL, the first line, but look how magnificently the pirto works in first line of mantle cell lymphoma. The safety profile of pirtobrutinib is something we should mention, because if you look at this 20% of neutropenia, that is the only grade 3 adverse event, and it does not correspond to the number of infections. All other grade 3 events are one-digit numbers. It's the best tolerated BTK inhibitor. And the final confirmation will come from the Bruin 321 study, which is completed, but we are waiting for its results, where pirtobrutinib was challenged any other BTK inhibitor given. So with the development plan, well, let's skip it for the time being. Now, the CAR T cells for relapsing refractory mantle cell lymphoma give you a great efficacy, because if we have in this high risk group the overall response rate over 90%, with a majority of responses being complete responses, with a very good progression-free survival, 60%, and with a very good results regardless the risk factors, it should be recommended to anyone who may get this therapy. Now, why I give the CAR T cells after pirtobrutinib, I have one good reason for it, because I do believe that the CAR T cells work much better if we have the patients who are literally with a smaller tumor burden. So if you have a relapse of a patient with a small tumor burden, you can go for the CAR T cells if reimbursed. But if not, it may be better to cytoreduce the tumor burden with pirtobrutinib and then observe the patient closely and proceed to the CAR T cell the first moment they start to progress. The treatment adverse events of CAR T cells are in line with what we observe in other CAR T cell therapies, but the icons are frequency with grade 3 are fully manageable. And certainly the duration of response depends on the response. So in those patients with a CR, we can achieve a longer duration of response, but that's self-explanatory. Now, that's something we should discuss, because we mentioned that bendamustine rituximab was the best therapy for the mantle cell lymphoma first-line elderly patients. And here we got an interesting story by Professor Michael Wang from MD Anderson, where he looked at the CAR T cell results, and it occurred that it's not just whether we use bendamustine in the last 6 months, but it's also the difference is also whether we ever used bendamustine. So this is a kind of argument that perhaps the elderly patients with a low tumor burden and low dynamics should be treated with just BTK inhibitor and monoclonal antibody. The real-world evidence is the same as what we observed in the Zuma study, which is a nice confirmation that the CAR T cells do better even in the very high-risk cases. Now, just to end in a very few slides on what else we can do, the combination of BTK and BCL2 inhibitors is a very nice one, with the BTK inhibitor allowing to shift the cells from their own microenvironment to the bloodstream, where they are more efficiently damaged by the BCL2 inhibitors. And there is a synergism we observe regardless which BTK inhibitor we use. And the Simpatico study, which I demonstrated you results in a treatment-naive patients, The true simpatico study was done in a relapsing refractory patients where we randomized patients with versus ibrutinib versus placebo and venetoclax. The groups were well balanced, and we could clearly demonstrate that the combination therapy does better in terms of median progression-free survival, regardless the subgroup we analyzed. Duration of response is longer, and even overall survival may demonstrate some benefit. Adverse events are clearly comparable, but the overall survival and may be actually better only after COVID-19 censoring. So again, the same sort of story we had. In the simpatico study, what may be important if we look at TP53 mutated patients, that they are doing much better on the doublet, and it's regardless which line of therapy. So you have the treatment naive patients in a velvet line and relapsing refractory patients on the green line. Certainly the patients without TP53 mutations are doing better. And if we look at overall survival, again, both curves in treatment naive and relapsing refractory patients treated with a combination of ibrutinib and venetoclax did much better. Sonrotoclax, I already mentioned, it's a drug you should think of, specifically if talking about the clinical studies, and it has an excellent efficacy. Let B1 fully develop it and get approved. I very much like the sonrotoclax plus zanubrutinib combination, and there is a randomized study in a chronic lymphocytic leukemia which is being launched early next year, when sonrotoclax plus zanubrutinib is randomized versus venetoclax and acalabrutinib, and it gives you the impression of how effective this combination it could be if the company decided to run such a comparison, hoping for a swift win. Now, the last bit of story is about the BTK degraders, which are a very interesting group of drugs. We have at least 3 companies developing BTK degraders. Nurix is perhaps a small company, but most advanced one. And then we have B1 and AbbVie. And if you look at the long-lasting answers, they are very nice indeed. But they are all preliminary data. You will see them updated on ASH. For you, I would just like to introduce you about the naming system, because someone decided in the States that the name of degraders will be totally different. So it will consist of the first part of the name, which will be a compound specific. For the Nurix component, it's a Bexo. Then the second part of the name will indicate which enzyme is going to degrade. So it's Bruton kinase, so it's Bruti, and then it will be clearly indicated that it's a degrader. So Bexobrutideg is the most likely name of the Nurix compound when it's going to be approved. Now, just for your own merit, there is a difference between molecular glues and PROTACs. Both of these compounds effectively end up in an increased turnover of the proteins and proteasome. However, the molecular glue are as smaller particles which go through the blood-brain barrier but has a less specific binding, while the PROTACs are the larger particles which actually combine to both proteins and bind them before actually getting them to proteasome. Now, if only lenalidomide would have been developed early enough, we would have a totally different picture nowadays. But the company didn't want to do it, and that was perhaps because lenalidomide was the drug with the longest patent right protection, or at least in Europe and in US. That's one of the reasons why the whole world was buying the lenalidomide generic from India. And that was a reason why I sent my patients to Ukraine before the war to buy the drug there instead of paying a 200 higher price in Poland, which was an European community. Nevertheless, in some of the diseases, the immunomodulation is good enough. However, in some of the diseases, we need the degradation, and I think that a classical case where lenalidomide doesn't work and degraders do could be a chronic lymphocytic leukemia. In diffuse large B-cell, it's the opposite. We usually use the molecular glues. With a mantle cell lymphoma, we most likely use both. Bispecifics, short story, not enough data to fully recommend it. So in a relapsing refractory setting, I showed you the European guidelines at the very beginning, and the same thing here. The recommended treatment algorithm has to take into consideration what do we have before, but sooner or later we will go through BTK inhibitors, then pirtobrutinib, and then CAR T cells. And again, that's a potentially, instead of summary, that's a potential algorithm depending on whether or not we are talking about the relapse after the continuous BTK inhibitors or without. So the landscape is changing, and we are shifting BTK inhibitors to the first line, which allows us to use the third generation BTK inhibitors or CAR T cells in the second and third line of therapies. Now, all the progress in mantle cell lymphoma was done in Europe by EMCLN group, and I just want to again introduce you Martin Dreiling, who is definitely #1 in Europe, and he's our Kaiser, and that's our strength, because even if they have Michael Wangen, MD Anderson, he is just MD Anderson. In Europe, we have a collaboration of different centers, and that's perhaps why maybe except for developing BTK inhibitors, the progress we made in Europe was better than the progress done elsewhere. Sorry for prolonging my speech, but 7 a.m. in the morning makes me below my expectations. Thank you.
Thank you so much, sir. Wonderful lecture. I think you covered almost everything. It was fantastic, sir. And with this, we'll start our question answer session. I request all our discussants to please put the hand raised signs. Yes, we have first Dr. Roshni Pandey, ma'am. Please go ahead.
Good morning, sir. Thank you for that excellent talk. The first question is related to SOX11. Is it just a diagnostic marker, or can it also be used as a prognostic marker in mantle cell lymphoma?
Thank you for this question. I would say that even if you have a SOX11 negative case, but with lymph nodes and a progressive disease, I would not call it an indolent mantle cell lymphoma you observe. So SOX11 is a nice confirmation of the indolent no-nodal lymphoma, but only if you have a non-nodal manifestation of the disease. So I would not make any decisions based on SOX11 as the only marker.
The
But
second,
it's a nice confirmation.
the second question is there any role of maintenance rituximab after autologous stem cell transplant? And in which patients, if at all, it's recommended?
Well, I mean, we can discuss whether we need transplant or not, but we can't discuss whether we need maintenance or not. I remember the study where we had this transplanted patients randomized to rituximab maintenance versus no maintenance. And we went for the MRD testing because in this study we transplanted everyone. And if we looked about the MRD negative patients from the bone marrow, and this MRD negativity was done centrally by Christian Pott, so that was the best MRD we could have in Europe. And the patients with a negative bone marrow before the transplant, so we should say the cured ones, underwent the transplants, and we looked at the randomization of rituximab maintenance versus no maintenance, and the curves were separated. Therefore, it's a proof for me that we know few things which we are certain about, but we are certain that rituximab maintenance should be done for everyone. Whether it has to be done for 2 years or 3 years, it's something else. Whether it has to be done every 2 months or every 3 months, it's something else. But because we are going for the rituximab maintenance, then it's again, I underline and underline it on every occasion, we should vaccinate our patients before we even start therapy. Because let me remind you that the efficacy of vaccination would be about 80% in lymphoma patients before therapy, but less than 20% in the patients after rituximab exposure. So rituximab maintenance is one of the underestimated things in the era of BTK inhibitors, but it's cheap. It's it's cost-efficient way of prolonging life.
The third question is there any role of a triplet upfront, say in elderly patients or transplant ineligible young patients? Triplet in the sense rituximab, ibrutinib, and venetoclax. And then how long does one give it?
Well, I would say that you mentioned two things which are contraindicated, which do not match. Because if we are talking about a young patients with high risk, they go to the transplant. But if you're talking about the elderly of the high risk, and this is the majority of the population, and I agree that if you look at the NCCN guidelines, they do recommend the triplet. If affordable, I would go for it. And how long? That's a very good question. We do not have the good data on that. I think that the minimum is 2 years, and then we can play with the MRD negativity if you want to.
Thank you, sir.
And definitely with rituximab, and here I do not agree with the FDA guidelines where they just mention obinutuzumab. We don't need obinutuzumab in mantle cell lymphoma. Rituximab does the job pretty nicely and is much easier to use.
Thank you so much.
Thank you, ma'am. So there are some questions from the audience. Dr. Karthik wants to know, before that we'll go with Dr. Shyam. Can Ven plus Zenu plus obinutuzumab have potential to replace the existing standard therapy in newly diagnosed mantle cell lymphoma?
Sorry, it was a question about obinutuzumab.
So all the triplet, zenubrutinib plus venetoclax plus obinutuzumab, all the three together upfront, can it replace the standard therapy in newly diagnosed mantle cell lymphoma?
Well, if you look at the European guidelines, we still do not recognize this P53 mutated patients as a second category. In FDA guidelines, I think they quite correctly went one step further, and they do recommend that those patients are treated either according to triangle protocol or according to simpatico protocol. The simpatico was a company-sponsored study where they didn't give rituximab, which was a big mistake. So it's one of the major drawbacks of this study. So again, if I treated my uncle, I would give him the triplet, but with whatever BTK inhibitor, venetoclax, and rituximab, and not obinutuzumab. If I were treating an NHS patient which could sue me afterwards, I would perhaps do it according to the guidelines. Now, whether to use in Europe, I would be fully justified to use European guidelines where this doublet or triplet is not yet recommended. In the States, I would use NCCN guidelines. In India, well, I don't know what to recommend here.
Thank you, sir. Another question he has is, can CAR-T replace autologous stem cell transplant in mantle cell lymphoma?
Well, yes, I mean, we can clearly omit the transplant in a low-risk patient without a P53 mutation, without a blastoid morphology, with low Ki67. And then the transplant is not necessary. Then I think that we can clearly omit the transplant in MRD negative patients after the induction. And this was proven by randomized protocols. It's fancy because we cannot omit rituximab maintenance. We may omit the transplants. Now, for the high-risk group with a blastoid morphology or high Ki67, transplants are a recommended therapy. With a P53 mutations, we do it because we can't have any, we can't suggest anything else, but it may not be a recommended one. We do it because we want to do everything.
Thank you, sir. Another question is from Dr. E. Montent. She has a patient of mantle cell lymphoma who is very aged, 80 years old. What would be the treatment and what would be the maintenance strategy?
I would put it like this, that if we are talking about 80-year-old one living in Scandinavia, maybe chemoimmunotherapy. If I had 80-year-old in Poland, and perhaps your Indian patients are in more like Polish patients in terms of the ECOG, comorbidities and everything else, I would just treat these patients with BTK inhibitor plus rituximab, unless those patients would have a high-risk features, and then I will ask myself a question whether or not additional venetoclax would be of benefit. But again, as I mentioned in my previous questions, it does depend from the patient's and the family's attitude, because it is not in the guidelines, at least in European guidelines as such. So if you ask the patients to pay for therapy out of their own pocket, and then you don't have a true proof that this is going to be successful, then you have to look what your legal position is and whether the patients will be nice to you or whether the patients will send you the lawyer.
Thank you, sir. Another question is from Dr. Churgutis. Which MRD monitoring method is used for patients taking decision about autologous stem cell transplant?
Which method? Sorry, which?
Which is the MRD monitoring method in your country?
Monitoring?
Yeah.
We don't. I think MRD is an investigational method we can use MRD analysis if you want to fish out the patients for transplant versus no transplant.
Yeah.
But after the transplant is done, we don't usually care because rituximab maintenance will be for 2 or 3 years anyway. Now then, if we have a relapsing refractory disease, we in any of the protocols, we do not retreat those patients in a clinically complete regression MRD positive status. We just wait until you have a symptomatic disease and treat it accordingly. Certainly, monitoring those patients in terms of how frequently you see them depends from the patient's knowledge of the disease. The less they know about the disease, the more frequently you have to see them. Frankly, as we do not, it's not necessary for us to fish out those patients very early in the disease course. I know that will be regarded as the old-fashioned one, but I think that perhaps ultrasound, if done skillfully, is good enough. I see just one clinical case or one group of patients where I always do the PET scan on 1 year after the end of the first-line therapy. And this is the diffuse large B-cell lymphoma patients, but I do it only because that if I fish out the early relapse at day 300 and a day before 1 year, they are eligible for the CAR T cell. If I fish it out a day after 1 year, they are not eligible for the CAR T cell in the second line of therapy. So that's the only PET scan I do in all cases. Well, okay.
So
The others, I try to do PET scan after 1 year in Hodgkin lymphoma and diffuse large B-cell lymphoma, but that's aggressive lymphomas. In indolent lymphomas, we were not really fishing for the very, very early relapse because it doesn't change anything. I love ultrasound.
So by chance, if you're using MRD to make a decision about transplant, whether to transplant or not to transplant, what is the method you use for MRD assessment?
Well, let me put it this way. If you have a patient in a clinical study, we do a lot of MRDs, but this is for the research purposes. Now, if we are talking about the everyday life, the only place where MRD may be important is if you are willing not to transplant the patient who are MRD negative.
Thank you, sir. Another question is from Dr. Yimon Tent regarding BR versus Arch-op RDAP. What will be your preference, BR or Arch-op RDAP? BR versus Arch-op RDHAP.
Well, my way of thinking is you see the patient before you decide of how to treat them. And I know that I'm not answering your question directly, but I think it's insane to look only 2 months ahead. You should look at least 6 months ahead. So if I have the patient who evidently is not a transplant candidate, I would not like to drag him through transplant by giving him R-CHOP and perhaps R-CHOP DHAP, and then he will not tolerate it, and then I will have to go back to R-CHOP and then transplant him as a last resort. No, it doesn't work this way. I very much like this large statistics on which bendamustine rituximab with rituximab maintenance, the median progression-free survival was longer than R-CHOP transplant patients. So I understand that some of the patients' condition is poor because of the disease burden. And in these cases, patients, yes, indeed, transplants would be a good option, specifically if they are non-comorbid and relatively young. But if you see the patient with lots of comorbidities, just pushing them through transplant is perhaps not the very best idea in mantle cell lymphoma. We have a lot of other ways of therapy. We can only use BTK inhibitors and other drugs we have in the second and third line if the patient is alive in the in the second or third line. So I'm in mantle cell lymphoma, maybe excluding some blastoid forms with high Ki67. I'm not the advocate of a very intensive therapy, specifically if the patient is comorbid and elderly. If we have a 65-year-old gentleman and with a lot of comorbidities, and it's a different patient than if we have a 65-year-old gentleman with no comorbidities. Because if we have the life expectancy of about 5, 8, 10 years, why should we bother for intensity? With the drugs we have, we don't have to. And with intensive therapy, we may lose patients.
Oh, thank you, sir. Dr. Rashmi Kushwa, your question, please.
Yeah, good morning, sir. Sir, as you mentioned the role of PET scan as well as ultrasound in disease monitoring, so I just wanted to ask, is there any role of circulating tumor DNA to monitor the disease progression? Is it being used at your end of the world?
By the way, I mentioned that I love ultrasound to monitor the patients, but certainly it's not the truth during therapy. Because during therapy, we want to see what's happening and we want to have this early PET CT response assessment and all that. So during therapy, we certainly do PET scans even more frequently than just a diagnosis and at the end of therapy. But you ask about ctDNA, yes?
Yes.
And we put it in our European guidelines that in diffuse large B-cell lymphoma, it may be used as one of the accessory factors, but we do not have the hard evidence that in mantle cell lymphoma, it's may be used in clinical practice yet. So it's developed investigational, but unless you do it within a clinical study, I would not regard it necessary.
Thank you, sir.
Thank you, Dr. Rashmu. There is one question which has come from Dr. Leaky Tat. In a young fit patient who is stage 4 mantle cell lymphoma with CNS involvement, what would you recommend? Would you recommend R-CHOP plus ibrutinib with R-DHAP followed by ibrutinib maintenance? Or you can straight away go to rituximab plus high-dose cytarabine containing induction followed by autologous stem cell transplant consolidation?
Once we had the story about the central nervous system lymphoma in mantle cell, it's more frequent than we may imagine. I remember that 10 years ago or more, Cheeth had a paper on the incidence of CNS involvement in mantle cell lymphoma. And at that time we thought, whoa, we have ibrutinib, that's a wonder drug, we should use it and everything is fine. Nah. Unfortunately, for whatever the reason, the responses to ibrutinib in the central nervous system, regardless whether you're talking about diffuse large B-cell lymphoma or mantle cell lymphoma, are short-lasting. Therefore, if you have a youngster with central nervous system involvement, it's a very, very high-risk case. So for the youngsters, high-risk patients, I would find enough rational to put him to the triangle type protocol, where you had a BTK inhibitor during the phase where chemotherapy doesn't penetrate the central nervous system, then you have at least intermediate cytarabine dose in DHAP. Perhaps I would increase it, because frankly, we are talking DHAP. I understand we had a DHAP in Triangle. I never use DHAP in mantle cell lymphoma transplanted cases. I think that the only thing which works there is cytarabine. So I'm putting them on ERHAT, which means rituximab, and cytarabine. And an ERHAT regimen developed originally by the Nordic group, the dose of cytarabine dependent on the age of the patient. So I would, such a patient, put on ERHAD with an increased dose of cytarabine, or rather not increased, but just per Nordic protocols. It was twice time, 2 grams per square meter, the total of 4 doses. That would have been a reasonable therapy for the central nervous system in this particular case. And in this protocol, if the patient is still alive and responsive, I would definitely go to the transplant. And perhaps, if economically possible, I would put a CNS dedicated conditioning regimen with Carmostin, BCNU, and things like that. But it's a very difficult case. The prognosis is poor, and whatever we would have done, the chances of losing this battle are greater than the chances of curing the patient.
Thank you, sir. Dr. Karthik wants to know if a young fit patient, TP53 positive, mantle cell lymphoma, what would be your approach?
Sorry, if the young patient,
TP53 mutated mantle cell lymphoma,
what's the approach?
yeah.
Well, the definition of young means that we do not have the right to put him on doublet and triplet with venetoclax and BTK inhibitor. Such a patient, the best, which is a standard, would be the triangle. And if you look at the results, the long-time results of TP53 positive mutated patients in triangle, they are not magnificent, but they are better than anything else. Having said so, I would put this patient wherever possible to clinical study. And this was the study we are currently running in Europe for such a high-risk patients, allow for the CAR T cell as a consolidation of the first line therapy.
Thank you, sir. Another question is from Dr. Chand. Is there any role of single agent venetoclax where BTK inhibitors are intolerant?
Well, I mean, I see very few patients who cannot tolerate BTK inhibitors. Specifically, if you are using the second or the third generation BTK inhibitor. But if it is a true intolerance, I would just address the question, what is the patient's status? Because if we are talking about a relapsing refractory disease, and I believe that's what we are talking here, then if available, CAR T cell would be a good option. A single agent venetoclax, I don't have the experience with. I do have experience with single agent sonrotoclax, and that's the killer. But whether venetoclax will do the same job, I don't know.
Thank you, sir. And the last question is from Dr. Karthik. If you can please summarize for all of us regarding your plan for high-risk mantle cell lymphoma for the patient who is young, fit, as well as unfit patients, how to approach. One nutshell, one summary. High-risk mantle cell lymphoma, fit and unfit patients.
Well, high risk, young and fit, triangle protocol. High risk, comorbid and unfit. It all will depend what is the high risk. If the high risk is due to the blastoid morphology or high Ki 6 to 7, perhaps still some kind of BTK-based chemoimmunotherapy would be recommended. So like BR plus acalabrutinib. However, if the high risk is entirely due to P53 mutation, then we would have to consider BTK inhibitor plus venetoclax plus and monoclonal antibody. But again, I'm saying if you are allowed to treat beyond recommendations, or if in India NCCN recommendations would be good enough for the court. Because in Europe, once we have the EMA recommendations where such a triplet is not recommended, I would think twice. In India, once you have one European guideline and one American guideline, I would try to be brave and choose the American guideline.
No, sir. So, sir, thank you so much. There are no more questions left in the chat box. Any discussants want to ask any other question? Well, so, sir, there are no more raising signs and no more questions in the chat box. So thank you so much for the beautiful and lovely lecture. It was fantastic. A knowledge gaining session. We learned a lot from you and your discussions are superb. And we really appreciate your discussion, sir. Thank you so much.
Very much for inviting me, but 7 a.m. is not the time of the day where I'm best. So sorry about all the errors and sorry about prolonging the lecture.
So thank you. It's our pleasure, sir, to have you on board, sir. Thank you so much.
Bye.
Bye.